would like to thank all the organizing committee, Dr. Ali and Dr. Hussein, for having me joining this meeting. So I would like to talk about real-time cervical MRI. So this is a 55 years old gentleman complaining of cervical radiculomyelopathy. And then you can see this is the MRI. There's very clear this patient have a 3-4 disc prolapse with cord signals. And definitely this patient was prepared for ACDF at this single level 3-4. When we did an extension MRI on this patient, we were very surprised to see that there is a significant cord compression posteriorly at multiple levels, as you can see on this MRI. When you compare this neutral flexion and extension position, you can see you have a very significant difference between the three positions on MRI. Does this give you any idea that you may change your plan of surgery instead of going from the front to go from posteriorly? I think so. This is another patient with history of C3 to 6 laminectomy 3 years ago. And then the patient still improved for some while and then started to be progressive weakness, quadriparesis, and myelopathy. We did an MRI on this patient, and clearly you can see there is no significant cord compression on this patient, and you can see plenty of room, but the spinal cord looks thinning at the apex of the kyphotic deformities that this patient developed. We did a dynamic X-ray. As we all know, there's a kyphose, but when you see the flexion MRI, you can see a very significant cord compression posteriorly here with the scarring element that this patient have after laminectomy. And each time this patient flexing his neck, there is a trauma to the spinal cord and compression and squeezing of the spinal cord, as you can see. And this is when you compare the neutral and flexion with the same patient, is very significant cord compromise with dynamic movement of his neck. Another patient with 2-level disc prolapse, and when this patient do extension, you can see how very significant cord compromise and compression with moving his neck each time. Another patient have a history of ACDF at 5-6. And then this patient extending his neck while he is still complaining, you find a thickened ligamentum flavum that is compressing the cord posteriorly after surgery. So the question is, we have a normal physiological change that happened to us while we are moving our neck. But what's the clinical significance for this? That this is going to change your management plan, your decision, instead of going from the front, going to from the back. And how to do this, and what's the predictive criteria? Who is the patient that I need to ask for a dynamic or flexion extension MRI for? Actually, this started like 1998, where they starting the mole classification in different positions, flexion, extension, and neutral. And then there's a lot of studies later on showing the normal physiological changes to the spine and the cord. They show how there is significant change in the foramen with flexion comparing to extension. Again, the height, the width of the frame change significantly. The spinal canal and the dural sac spaces anterior and posterior to the cord with flexion and extension, especially at C4, 5, and 5, 6 levels. Again, you can see this is in the neutral position. You can see there is no significant cord compression, but you can see there's a lot of signal voids inside the cord. And when the patient extends the neck, you can see a huge and significant multiple cord compression at multiple levels. So again, there is a functional compromise to the cord with extension, and they proved this actually with doing a somatosensory evoked potential while the patient extending his neck. And this study, they brought up volunteers with normal patient and cervical myelopathy patient, and they extend their necks for 10 minutes and then 20 minutes, and they found that the waves is markedly significantly decreased while they extending their neck for some time. Again, this is another study looking for the significance of or functional cord compression with extension. And it's not clear here, but they show that a lot of surgeons changed their mind and their decision after they did a dynamic or flexion extension MRI. So what's the predictive criteria? Any patient I need to do a dynamic on, or there is selective type of patient. So this study looked for cervical curvature, degenerative stage, canal stenosis, or instability and cord signals, and trying to find which of which this patient can have a significant impact or results while they are doing dynamic. And they found advanced degeneration, and the spinal canal space is very predictive criteria. So patient, when you see market degeneration, so probably the dynamic will show positive effect. During a flexion extension, it's easy, just put a pillow and do a regular routine MRI. Some people use a device, but at the end, we need to say that there is a physiological changes, and they prove this with somatosensory evoked potential. The flexion extension is tolerable to the patient, and actually, at some point, you can change your plan with doing this. But the new is what's real-time MRI. The real-time is continuing our continuous filming and monitoring the spine while the patient is moving. So can you do this in the cervical spine? It's never done before, but actually we found this in the literature. They start doing this in the joint, and you can see here when the patient moving the wrist, and you can see the bone and the joint is moving while they are filming this live, and actually is very interesting. This is another real-time MRI while the patient is speaking, and you can see how he's moving his tongues, and actually it's very interesting. So we said, can we do this to the cervical spine? I think we can do, and there is a lot of studies like this starting to emerging up using the MRI real time with the shoulders, and this one looking at the joint cavitation while pulling the finger, and they are recording this with MRI. Another one using real time with MRI with biopsy in the brain. And they did this with the knee, temporomandibular joint, hips, and so on, but never in the spine yet. So we said, let's try this. And actually, we succeeded to do this in our university. And you can see this. This is a patient volunteer, while we can do a real-time cervical MRI on this patient, and you can see how we can record this moving spine. This is actually an interesting case. This is one of our colleagues, 40 years old, complaining of neck pain, and he's starting to have myelopathic sign. He is an orthopedic surgeon. And then this is an MRI. You can see there is a significant cord signals up at the C1 posteriorly. And this patient was screened for MS and neurodegenerative disorders, and all of them were negative. And then we did a somatosensory evoked on him. It was positive. لو سمحت مش بيقلب. Okay. تمام. So when we did a dynamic X-ray on this patient, we start seeing there's some abnormalities in the posterior arch of C1. And you can see they have a congenital anomaly type C at the posterior arch. The posterior arch is floating and it's not connected to the anterior arch. So I started looking at the literature, and I found a paper saying there's a proposed mechanism when this patient extending his neck, this posterior fragment is pushing and compressing on the spinal cord posteriorly. And they said, let's do this and try the real time here. And actually, we did the real time on this patient. And look at the posterior arch of C1 while the patient extending his neck. And you can see how dramatically this piece of bone is squeezing the spinal cord while he is extending his neck. He said, when I extend, I see like an electric impulse in my hands every time. So, and you can see here, this is a neutral position, and this is the extension position. And you can see this floating piece of bone is compressing the cord, actually. So we believe that real-time MRI is in early stage, is encouraging, and it can give us an idea about understanding the pain mechanism, instability, and the functional anatomy. It's still an expensive, the imaging is not that clear, and there is no standards yet, and it's costly, but probably by the time it can be improved and help more understanding all the dynamic movement of the spine at the end. Thank you very much.